I like to start with this slide because this slide highlights that everything that I'm going to talk about when I'm talking about animal models is going to involve Eric Nürnberger, who's in the audience. And I do that so that you know that as soon as the hard questions come, I'll just point at him. Unfortunately, I can't see him right now, but I'm sure I'll find him when I need him. So we do most of the work that I'm going to describe today that encompasses animal models at Johns Hopkins University with Eric Nürnberger. A lot of you are familiar with this model, but I'll describe it anyway. Eric infects the mice with about 3 or 4 logs of organisms at 2 weeks before they start therapy. They let the organism incubate for 2 weeks, and then they start therapy at what they call day 0. And at about this time, the organisms have grown from about 3 to 4 logs to about 7 to 8 logs. And then therapy starts at day 0 and goes on for as long as you want. And at some point where you decide, so at month 1, for example, you can harvest the lungs and see how many bugs are there after a month of treatment in the lungs. And then the rest of the time, you can continue to treat. And when you want to see if you've cured anything at all, or if you have failed to cure, you hold the mice at the time point of your choice. You hold 15 mice for 3 months. And then at the end of the 3 months, you see if there's anything that's still growing inside the lungs. And if there's nothing growing, then you've cured. And if there's still some growth, then you know that you've had relapse. It's just as simple as that. So then you're able to gauge or rank a regimen that cures everything at 6 months or 5 months, like the standard of care, versus a regimen that is better than that. I just thought I'd remind you that so that you know. So that, for example, then we ended up with a regimen of bedaquiline, pretomanid, and linezolid that actually cured all the mice at about 3 months, and at about 2 months of therapy, it was better than or equivalent to the standard of care at 3 months. So you see this improvement because these mice at the standard of care are still not cured at 3 months, and they'll probably be cured at about 5 to 6 months, whereas the animals that are being cured by the new regimen of BPAL, which ended up being the next regimen in the clinic, was curing all mice at 3 months. This was then the next regimen that went into the clinic that a number of you in the audience already know about. This has been a very successful trial. It was based on the fact that the XDR patients had no options, and therefore we were allowed to go ahead and use in those patients, the XDR patients, a non-approved drug, pretomanid, bedaquiline, which was only approved for MDR, and linezolid, which was already out there in the clinic, but being used without any approval for TB. So that regimen went into the next trial, and that happened in South Africa. And this is the update as of about the end of last month. 28 out of 102 patients cured. 30 patients had already reached the first time point of 6 months of relapse of no organisms that could be detected. There was no relapse up to 6 months, so that's the first endpoint that we're looking at. So 30 patients have already passed that. No patients were lost to follow-up, and we think we're counting the cure right now, the durable cure, at about 87 or 85%, and that's because of 4 patients that died earlier in therapy, and that was mainly because they were too sick to be salvaged. Unfortunately, though, and this is what brings us to the talk today. I'm going to show you why in this regimen of pretomanid, bedaquiline, and linezolid, why we thought we had to replace linezolid and why we had to replace bedaquiline. So linezolid, unfortunately, has these toxicities that you all know. It causes myelosuppression and peripheral neuropathy in patients. It was manageable within the trial, but with significant monitoring by the physicians. They had to intervene at some point. They had to reduce doses. They had to have dosing holidays for linezolid, and in some cases, they had to prematurely discontinue therapy. And only 4 patients, at 100 patients already looked at, only 4 patients completed their linezolid therapy without any of these interruptions. So we figured then at the TB Alliance that a safer and better tolerated oxazolidinone would be a much better thing to have because it would increase efficacy. First of all, if you could dose it higher if you needed to, but also just by keeping the patients on therapy for as long as you could. So for that, this is another example of the toxicities. In red, you see myelosuppression that comes up Myelosuppression comes up, mainly peaks at about 2 months of therapy, and then it continues the rest of the time. And peripheral neuropathy peaks at about 4 months. So these are all linezolid toxicities that we figured we should remove. So what do we know about these toxicities in oxazolinones? These are all the oxazolinones that you know about that are out there in the clinic. You have linezolid, sutezolid, an agent that was developed by AstraZeneca for a while called posezolid. Ridezolid never went into the clinic. It was from Rybex. And then there is a compound from Johnson & Johnson that only went, I think, to phase 1 in other indications, not TB. And then there's tedizolid that is at Merck. All of these agents are all characterized by this unfortunate amount of mitochondrial protein synthesis inhibition. So the number is very, very low, and it's almost equivalent to the MIC of those drugs. So we figured that if we were to go back, starting with these compounds here as our starting point, and go and develop a novel oxazolinone that would be devoid of the MPS, of the mitochondrial protein synthesis inhibition, but either maintain or do better for the MIC, we would get a window that would give us safety and probably a better compound. So that's what we went and did. I won't go into the chemistry because I wouldn't be able to even if I tried, but I'm sure you're not even interested. But this is the compound that we ended up with. It's called TBI-223. Briefly, the pharmacology looks like this. Its MICs are similar to those of linezolid against tuberculosis, both in vitro and in macrophages. It is active against both drug-sensitive and drug-resistant strains, obviously, just like linezolid, because there's no pre-existing resistance against TB for oxazolinones. It has no known pre-existing resistance, obviously, as I said, and the frequency of mutation is reasonable and similar to that of linezolid. The pharmacology for this compound is that it is bactericidal in acute TB, but not very bactericidal, just mildly bactericidal, just like linezolid. It is active in the next regimen, as you're going to see in the next 2 slides, and we figured that a compound like this, if put into the next regimen in place of linezolid, it would give us a better and improved regimen. We went and looked at the in vitro safety toxicity of this compound, and we found that there were no signals in 44 human target screen except for MAOA and MAOB, just like linezolid, but even those numbers were improved over linezolid. As I said, this was our biggest, every compound that we made, after we figured that it was active against TB, we sent it right away to our CRO, to a CRO we worked with in China to look at MPS, mitochondrial protein synthesis inhibition, and this compound came out at this nice number of 87 compared to about 5 to 10 for linezolid. We tested it against, we went to another CRO that has a bone marrow suppression assay, and we looked, and again, the compounds were safer. It had no hERG inhibition. Cytotoxicity was good, and it had no genotoxicity. Ames was negative, and macronucleus assay was negative. We went and did, so this is now a summary of all the in vitro and vivo toxicity studies of this compound. We did a 14-day dog study and a 28-day rat toxicity study with this compound compared side by side with linezolid, and this is what we found. So the first row looks at the MICs again, they're similar. The MPS, this is linezolid, this is our compound. The AUC at 100 mg per kg for both compounds, our compound is exposed just a little bit better than linezolid, but not by much. But when we went to bone marrow toxicity, as looked at from these assays at 150 mg per kg for linezolid, you already had issues, all of these issues. You had bone marrow reticulocytes go down, platelets go down, and the animals were unhappy. Such that, for example, that at day 11 and 12, animals dosed with linezolid at 300 mg per kg were dying, and all of the animals had to be sacrificed at about day 15. And at day 21, animals at 150 mg per kg were dying under linezolid. We saw no deaths and no such issues with our compound, and it was clean up to 300 mg per kg, which was the highest concentration that we used. maybe higher than that, I can't remember. Anyhow, the toxic effects to mitochondria in sensory axons and Schwann cells, according to this publication here, they think that they may have something to do as well. That may be the reason for the neuropathy. So we think, even though we haven't proven it yet, we think that reducing the MPS activity, we may even affect a positive result for the neuropathy as well. Even more important, or at least another way of looking at the improvement that we've made, is that when you take, this is taking together all the studies from 3 animal models, mouse, rat, and dog, and looking at the exposures, and then and doing dose projection on that, we expect that this compound is going to be the projected human efficacious dose is going to be about 800 to 1300 milligrams per day, just like, so pretty much in the same range as linezolid, if you use AUC. But if you use time above MIC, we think we can even get away with 600 mg per kg. So we're going to figure that out when we get to phase 1. But what's even more exciting is if you look at this graph here where we show that whereas the MIC for this compound is down here, and the MIC for linezolid is at about the same place. For linezolid, this is the MPS, this is where the MPS is at. And when you look at exposure with 600 mg per day for linezolid, this is what you get. So a bunch of the exposures per day are way above the MPS, which is how you get the toxicity. Whereas for our compound, with the dose that we're expecting to get, we're going to stay where the MPS number is going to stay way above. We're going to be way above the MPS number is going to be below what we're going to be able to achieve for exposure, which is good. So to summarize then, the safety of linezolid versus our compound, the first row shows you that in red, the NOAEL for linezolid is 20, whereas for us it was about 75 to 200, depending on males or female rats. The exposure at NOAEL was about many times over the exposure for the NOAEL for linezolid. 14-day tox in dog for NOAEL, again, you're comparing 20 versus 150, again, a very nice difference. And then the dog exposure, again, ours were getting much higher exposure with no issues, whereas linezolid at 93 is already, you have issues. The clinical efficacious dose, clinical efficacy exposure for linezolid, 275 versus 175 for us, we think we're going to get away again, because we don't need as much exposure to get the efficacy that we get. And then all these numbers, these safety numbers, are basically based on comparing this efficacious dose versus this efficacious dose, or these issued doses for the rat and the dog. So again, our compound is doing much better than linezolid. So that then, in summary, gives us a compound that is similar to linezolid, potency similar to linezolid, MPS better than linezolid, and no bone marrow toxicity, and a compound that we think that if we can actually dose it once a day, whereas for linezolid sometimes we need twice a day dosing because of the exposure. And that gives us a compound that we think we can put in the next regimen, and it will do better than linezolid. So that was the story on the third compound in the next regimen, the linezolid. Now I'm going to take you to the bedaquiline story, because we figured that bedaquiline also had issues and we needed to do something about that. So bedaquiline is critical to new agents. As you know, it's actually one of the best compounds that is out there right now helping MDR patients together with delamanid and other agents. Unfortunately, the current limitation is that it is indicated only for for MDR and XDR TB. There's a black box warning that the compound was given upon approval, and it requires monitoring and requires ECGs, which is tough for places that are not very well resourced. So the utility of the diurequinolone class, therefore, should be maximized, and we think that one way of doing that is removing some of these issues, and actually maybe even have a safer margin. But importantly, we might even get superior efficacy if we can keep improving on the exposure. So again, forgetting about the chemistry, except highlighting the fact that we started from bedaquiline, which is this compound here, to this compound, which is TBAJ 587. And for those that are chemist-minded in the house, you can see that there's new decorations on this B ring over here, and there's new decorations on this C ring down here, and those are the changes. And that gave us a compound that was safer and cleaner than linezolid, as you're going to see, than betaculin, as you're going to see in the next few slides. So MIC, so in this case, not only are we trying to improve on safety, we're also trying to improve on potency and efficacy, because we could tell that we could. So MIC, betaculin versus our new compound, you can see the difference is about 10 to 100 times better. MIC under non-replicating conditions, also better. And then when you just look at the clinical panels of our organisms that have come out of the clinic, again, we're at a much lower range than betaculin. Our compound is also more cidal than betaculin. This is the MPC, so that if you go into macrophages and you treat for, I think it's about 7 days of treatment, you can reduce, with our compound, you can reduce by 1 log the treatment in macrophages with no reduction versus betaculin. This here at the bottom shows you now activity of our compound versus betaculin and its metabolite, and then our compound and its metabolites, but just concentrate on the betaculin in the top row and the green row on our compound. This is now against the mutants that have been seen coming out of the clinic, starting with the efflux mutant 067, and then these are various mutants that we got out of Janssen. And again, our compound, even though it's affected, the MIC certainly goes up, but it's still at a much lower range than what you see for betaculin. In vitro safety profile, again, you look at viral cells, HepG2 cells, DNA in HepG2 cells. Phospholipidosis was the only thing that we don't seem to have affected. It's just like betaculin is safe in AIMS and safe in the micronucleus, but this right here shows you how better we have done. Importantly, and this is now going to the cardiotoxicity, for HERG, whereas for betaculin, this is the number, this is our number for our new compound, many times better. We also went in and looked at the potassium channel and the sodium channel for our compound, and we found that sodium channel, our compound, is much less active compared to betaculin, and we also looked at the sodium channel, for which was we don't have the data for betaculin from Janssen, but our compound is doing very well there as well. These are the CEREP data, and also importantly, our compound doesn't see as well the mammalian ATPase, which is the exact target on the mammalian side, versus betaculin. So our compound is much less active against the human enzyme, whereas betaculin is still active a little bit against the human enzyme. So again, we think that these are going to be the reasons that we're going to have less cytotoxicity, and we're probably going to have a better compound, and we have reduced potency against the cardiac ion channels compared to betaculin. So, and then going in vivo now, we went and if you take a look at the AUC at the NOAEL for our compound is 40 mg per kg, whereas it's only 6 for betaculin, and therefore we have a better safety than betaculin, safety margin than betaculin. And then down below, these are in vivo studies now looking at findings from a 7-day and 14-day studies in rats. And you see, again, that the NOAEL for our compound is 40 versus 60 for betaculin, whereas the exposure is much higher for our compound, and we expect that the clinical efficacious dose is going to be a little, clinical efficacy exposure for us is going to be about 10 times lower than for betaculin, and our mouse efficacy exposure was only 4 times that was required versus 4 versus 16 for betaculin. So we have a very healthy safety margin compared to betaculin, and we expect that our clinical exposure is also going to be lower, and we're going to have a low exposure. We can dose a little bit higher maybe, and we're going to have a safer compound because we've removed some of the toxicities, and we're going to have a more efficacious compound because we've improved on the potency as well. So the opportunities that exist now then, we think we're going to have superior efficacy and a shorter treatment time, and I'm going to show you some of those hints in the next few slides, because we're going to have a higher AUC versus MIC, maybe better suppress emergence of resistance, as well as you saw on the slide with the resistances, with the efficacy against the resistant cells. We have the equivalent efficacy at 10-fold lower exposure than linezolid, and we think we can dose daily because we have much better clearance than bedaquiline. We have a lower risk of QTC because of the data that I just showed you for ECG, but also for the ion channels, and we think we have a safer compound. So now, going back to the work that I referred you to from Johns Hopkins University, now we're starting to insert our new compounds into the next regimen to demonstrate that either we haven't lost efficacy or we've improved efficacy. So these are untreated organisms here, starting from the day when therapy starts to, what was put in at day minus 15, and therapy starts at about 8 to 9 logs. This is just bedaquiline plus pretomanid. This is the next regimen, all three drugs, bedaquiline, pretomanid, and linezolid, and this is now replacing linezolid with our TBI 223 compound. And you can see that as far as CFU reduction, the 3-drug regimens are better than the 2-drug regimen, even though the regimen with our compound is a little bit slow at the cytidal killing to start due to its a little bit higher MIC. But when you start looking for cure after 2 months of therapy, so this is where you've cured for 2 months and then you hold the mice for 3 months and look to see at the end. After 2 months of therapy, you haven't done much cure on either side. But when you get to the 3-month time point, now you are noticing that our compound is just as good as linezolid, maybe even better numerically, even though that is not statistically significant. But basically, this just shows that our compound is as good as linezolid, even though it is safer, because it hopefully will not produce myelosuppression in peripheral neuropathy. Now, replacing bedaquiline with the new compound, TBAJ587. Again, same setup. In fact, these two slides come out of the exact same trial. So now, though, you are looking at replacing bedaquiline with the new compound here, and look at the efficacy even after just 1 month of therapy. Look at the difference in CFUs. So this is reducing CFUs here from 8.9 to 4.5, here all the way down to 2.8. And now, with the new, much more potent compound at the same dose, you see that the same sort of cure that you get after 3 months of therapy for BPAL, the next regimen, you are getting after 1.5 months of therapy with this new agent. So substituting TBAJ587 for bedaquiline results in over a month of treatment shortening in this experiment. Going a little bit further, and I'm showing you data now from an experiment that is still ongoing. So the reason all you are seeing here are 15s, that means these are the mice that are still going to be looked at, but we now already have data coming out of 1 month of therapy. So this is a little bit busy, so I'm going to walk you slowly through it. So what we've done here now is we're comparing, let's do them one by one. The first part is we're just looking at what happens if you move the dose of the new compound from 25 mg per kg, which is the normal dose, and double it to 50, because we think we can now because we have a nicer window. And as you can see, cure after 1 month, 1 month of therapy, whereas for the lower dose, you are only curing half the mice after 1 month of therapy. If you double the dose, you are curing 13 out of 15 mice at that time point. If you go a little bit further, and I'm introducing, I'm cheating here because I'm sneaking in a compound that I haven't talked about yet, that is even more potent, that came out of the same effort as 587, that one is 876. So similar properties, except much more potent than both bedaquiline and 587. And that compound, at half the dose, so 12.5 compared to the 25, is also just as good, curing most of the mice after 1 month of therapy. Interestingly, and now I'm adding an even more complicated story because you haven't seen this, but most of you in the house already know this. Whenever you add pyrazinamide to any regimen, we always see an improvement in therapy all the time. So we were not surprised, for example, to see that if you take this regimen right here, the 25 PAO, and you add to it pyrazinamide, you do just as well as if you had doubled the dose of the 587. That's what happens. Well, the good thing about that is now you don't even have to add pyrazinamide, which has its issues and toxicities. You can just stay with the same compound except double the dose, and you get that sort of effect. Another trial that is still ongoing. Unfortunately, I don't have any data on it, but I just thought I would sneak preview so that maybe you can invite me to talk about it next time, is you know about JPAMZ, which the TB Alliance just ran into the clinic in a 2-month trial, and we saw very nice culture conversion after 2 months with this regimen. So this bedaquiline, predominant, moxi, and pyrazinamide. Now we have an opportunity to come in and substitute our new compound for bedaquiline in that regimen. So those studies are ongoing. I also am here to tell you that we have data that suggests that bedaquiline, predominant, linezolid, and pyrazinamide are also an excellent regimen that usually in our hands cures all mice in about 1.5 months to 2. So we can go into that regimen now and substitute in the new compounds, the new diurequinolone and the new oxazolone. So basically what I'm trying to demonstrate here is that the field is wide open for us now to create more and better and more varied and more efficacious and hopefully safer regimens using these 2 new compounds that we just brought in. How am I doing for time? 5 minutes? Okay. 5 minutes before questions? Okay. I thought I would go through this because I think this is something that Eric and I have been worried about for some time. We think about it all the time. People at TB Alliance obviously think about it all the time. And that's the question of, I just showed you a whole bunch of data from the mouse, and I'm telling you that we use that data to help us decide what regimens to move to the clinic, to EBAs and to 2-month conversion, culture conversion, and then also to cure. But how do we know how well we're doing as far as predicting what is going to work in the clinic? So what I'm going to show you now then are how the various regimens that have already been seen in the clinic now, that we've taken to the clinic, how they were ranked by the mouse model, and how they are ranking in the clinic to hopefully convince you that we're not doing as badly as one might think as far as predicting the efficacy in the animal model. So I'm just going to very quickly show you that if you take BPAMZ, which I just told you about, look at its efficacy. It cures about 12 out of 15 mice after 1.5 months of therapy, versus to what would happen if you don't have pyrazinamide there. I just told you that pyrazinamide makes everything better. Again, these 2 regimens, BPAZ and BPAMZ, are really good regimens. So when you take these together, then, if you look at PAMZ, which we also took to the clinic, it is worse by about 3 months compared to BPAMZ and BPAZ. So this is the ranking that you would come up with then. BPAMZ is better, followed by BPAZ, then BPAM, then PAMZ, and then the standard of care. I just told you about this new regimen as well, BPALZ, which is also good, is almost as good or slightly better than BPAMZ, so that would be ranking there. For the data that, I'm not going to show you any data today, but we know now with the data that we have at the TB Alliance that if you look through all the clinical trials that we've already taken, both in EBAs and also the 2-month culture conversion, this is how these regimens rank in the clinic. BPAMZ is definitely better than BPAZ, which is better than PAMZ, which is about similar to the standard of care. And this is exactly the same ordering that we saw in the preclinical status at JHU as well. So we feel good about this. We know that our job is not done. I don't know, I deleted some slides. But what I wanted to tell you about this is the fact that we are not necessarily satisfied. What I came to tell you today is that we're not satisfied about where we are with this. We're happy that we're here, but please consider this as a nice thing to have, but also good tools to have to now probe the systems, both the animal systems and the clinical systems, and be able to say, now we have more sensitive tools that we can use in the clinic to improve maybe our animal models as well. You have people like Mike Lyons here, you have Radha Savage, that are going to help us now take the data from the clinic through pharmacometrics. You have Jerry, we just brought in Jerry Needleman into the TB Alliance to help us with all of that, to ask the questions that this team here asks. How do we make these regimens better? How do we make sure that we're dosing them as best as we can to improve efficacy, avoid resistance, and avoid having to lose these drugs? So all this is still required. Tanda Gambo is going to be here at some point, and he's going to tell us about how to use the hollow fiber system to actually, again, come back to these regimens and look at them one by one, individual drugs per regimen, and figure out how to work better with them to make them what they can be. Vero is here. Is going to, she does wonderful work with us, looking at how can you go into the animal systems and ask the questions that we can't ask in the mouse, where you don't have caesium, you don't have necrotizing granulomas. She goes in there to look to see how are these individual drugs exposed per regimen so that they do the best work that they can do. Greg Robertson is here, who's going to tell us about how other animal models, other than just the mouse model, that have other properties in them. So take these tools that we have now that are much more sensitive, they show a difference between the standard of care and the new tools, and see how we can improve therapy. And I'm gonna stop right there. And thank you very much for listening.